So I think maybe we divide them into first trimester, second trimester, and third trimester. So in the first trimester, there are some blood tests that everybody does, and a scan. And then in the second trimester, a scan. In the third trimester, blood test and scan. So in the first trimester, the blood test we do routinely check for a full blood count, checking to see if we're anemic or whether we're thalassaemic. We also check for infection status like syphilis, hepatitis B, HIV. We check for vaccination status like rubella, hepatitis B as well. Some of us check for CMV, which is cytomegalovirus, to see if there's a recent infection in the first trimester, because if there is, there are now treatments that may be available that can reduce the chance of passing it on to the baby. We also check blood group. We also check for any abnormal antibodies to atypical red blood cell antigens that could sometimes cross the placenta and attack the baby's red blood cells. Lastly, we do a first trimester screen at about 12 weeks. This first trimester screen at 12 weeks checks for things like Down syndrome. We check the nuchal translucency. We look out for pre-eclampsia risk. We look out for structural abnormalities. The pre-eclampsia risk is now increasingly being done routinely, because we find that if your risk of pre-eclampsia is high at 12 weeks, giving aspirin reduces the risk by about 90%. And aspirin is low dose, it's easy to take, and it's very, very effective. So there are effective things that we can do to try and reduce those risks. On top of that, there are some optional tests, like there's also now non-invasive prenatal tests, where it's a very, very effective tool to check for things like Down syndrome, trisomy 18, trisomy 13. These are the three commonest chromosomal abnormalities. And so the advent of all this better and better tests now makes screening for abnormalities very, very effective. Of course, the flip side of it is that the cost has increased as well. Yeah. In the second trimester, we do a structural abnormality scan at about 20 weeks, where we look out for brain abnormalities, heart abnormalities, and there's a detailed list of checklists that we look at. We look at the baby's structural abnormalities. We also then measure the baby. We check that the placenta is not in a low-lying position. We check the blood flow to the uterus. And if the blood flow resistance is high, it also increases the risk of preeclampsia. We then check the cervix, because the cervix, if the cervix is short, it increases the chance of premature labor. Nowadays, we have medications that we can use to reduce the chance of premature labor as well. So these 5 things that we look out for in the 20-week scan is quite a comprehensive test for all this. In the third trimester, at about 28 weeks, we do another test to check for full blood count. We check for anemia. We check for gestational diabetes. We also, some of us are beginning to do iron tests to see if the patient is also got iron deficiency. Again, iron deficiency is so common. The demands of the pregnancy in the third trimester increases the risk of iron deficiency, and if iron deficient, we can give oral iron or sometimes even intravenous iron to supplement. Yeah. Some of us will then do a third trimester scan at 28 to 36 weeks to check that the growth of the fetus is okay. Some of the structural abnormalities appear late. About 1 in 200 pregnancies have got late onset structural abnormalities that cannot be picked up in the first or second trimester. At about 36 weeks, we do a vaginal swab from the lower vagina or the rectum to look up for this bacteria called group B streptococcus. And if the group B streptococcus is positive, then at the time of delivery, we need to give IV antibiotics as well. So that of course these are the routine tests that we do. Most of them routine, some of them we offer as an option. And depending on what we pick up, then it may result in more tests as well. You can define it on a few things, I guess. It can be because you had a adverse outcome in your previous pregnancy. So you had, let's say, previous miscarriages, previous chromosomal abnormality, previous premature labor, previous stillbirth, previous growth restricted baby, previous preeclampsia. So these are things whereby if you had a previous adverse outcome, there are now strategies that can help us reduce the risk of these things from recurring again. And so if they see a high risk, a doctor who specializes in high risk pregnancy and who's up to date with all these preventive measures, it can then help to sometimes reduce the chance, or to at least have strategies that will allow the doctor to pick it up when these things recur again. So if you pick it up early, hopefully you can do something about it. Also, it can be this current pregnancy. For example, if there is an abnormality on one of the tests, like a non-invasive prenatal test, high risk for something, where they may require an amniocentesis or a CVS procedure. These are procedures to check the chromosomes of the baby. Or if it's a twin pregnancy, because twin pregnancies have higher risk of complications like premature labor and growth restriction. It can be because the cervix is short, because at 20 weeks, sometimes they need a stitch or they need medication. Or they could be because they have a family history of abnormal children, or sometimes genetic conditions, and that means they may have to do more tests to check for a more comprehensive check of the baby. If mothers are older, the risk of miscarriage increases, chromosomal abnormalities increase, preterm labor increases, growth restriction increases as well. And I guess traditionally we've always used age 35 as a cutoff. So if you're 35 or more at the time of delivery, that's the cutoff we use. Yeah. So you could have, let's say, 10 babies, and then 9 babies normal, and number 10 is a Down syndrome baby, and that's because by the time you're number 10, you're 40 years old, 45 years old. Yeah. So 9 previous normal pregnancies doesn't mean that number 10 is going to be okay. 6. This one was a Caesar, the next 5 was natural. So the second one and onwards was a VBAC, a vaginal birth after Caesar. And she's funny because she's, she loves being pregnant and she loves kids. And every time she's pregnant, she comes in smiling and saying, "Oh, I'm pregnant again." And the husband who's walking behind her is frowning and saying, "Oh, I cannot retire."
I know that very often when the patients reaches like 10 cm dilated, the midwife or even the obstetrician sometimes would discourage them from having an epidural. It's not true that all patients at that stage cannot have an epidural, because that stage of labor, the second stage of labor, can last between like half an hour to up to 2 hours to 3 hours. And if this is your first pregnancy, then the chance that it is a longer period is higher. If this is your second and third pregnancy, then probably the second stage of labor is shorter. Then perhaps, delivery being imminent and all that, then perhaps you may choose not to have an epidural, because epidural is not without side effects. It's not fast working, it's slow to work. Sometimes it cannot catch up with the pain. And positioning, being in a good position and staying still for the epidural injection is very important. So when you are in severe pain, that is very difficult. So that is also the reason why some women are discouraged from having an epidural at that stage of labor. Yeah.
So maybe
but it can be done.
Yeah. So maybe the patient can actually ask the team in the labor ward, because if they think that the baby is going to come in the next 10 or 15 minutes, then obviously there's not a need for the epidural. But if the baby's, they think that she's still going to push for another 2 hours or so, and that 2 hours where she's pushing can be the most painful experience in her life, then the epidural sometimes can still be put in at that time.
Of course, some people may be worried that if the epidural is put in at that point in time, then the effort of pushing will be reduced, which is true. It is reduced, but of course you can get around it by coordinating with the nurses. The nurses will tell you when the contractions are, and then they'll time it and they will tell you exactly when to push, and you have to just work with the nurse. Yeah, that's right.
Yeah, I don't think they push less hard actually, but it's just that they have less motivation to push because it's not so painful. So they're quite relaxed, and yeah. But if they push, if they know how to push, they can still push it out quite well. Yeah. So With the epidural on, because you're not in pain, sometimes it's also not a bad idea to let the contractions do the work. Passively push the head down. Only when the head is very, very low, then you start to push. So yes, it prolongs the second stage of labor, but it doesn't necessarily reduce the chance of a vaginal delivery. Okay, so I think as age is one of the risk factors, and we do find that lately Singaporeans are getting married later, or if they're getting married early, they delay their pregnancy till later. So I think don't delay too long. Get married early, and if you can marry early, as early as practical, as early as practically possible. Plan for a baby, and the younger the woman is, the biologically the risks are less. Yeah, that's one. And two is do open up your ears and eyes to look out for any genetic conditions in the family. So, for example, like sometimes we have relatives who have got certain medical issues that are inborn. Sometimes it pays to know why they have it, whether it's due to a genetic cause, because nowadays there are a lot of genetic tests that one can do to see if one is now at higher risk of having the same problem. And because these are now tests that we can do even before you try for pregnancy. Third is read up about pregnancy, and if you're trying for a baby, go for a pre-pregnancy screening. Again, there are many things that we can do, and when you are pregnant, see the doctor as early as 6-7 weeks. Again, there are many tests that can be done. Yeah. Okay, moms who are already pregnant, see a doctor early, see at about 6 to 7 weeks pregnant, have a scan done. Well, I think importantly, alcohol is no good, smoking is no good, too much coffee is no good. Enough sleep, these are quite commonsensical things to do. And I guess avoid raw meats, raw fish.
Cats.
Oh, cats are for toxoplasmosis. So cats, I guess, if you have cats at home, make sure you wash your hands, don't touch the litter. And if you have to wash the cats, maybe get somebody else who's not pregnant to do. Yeah. Wearing the mask is useful. We did find that during the lockdown period, actually a lot of countries, places like Denmark, Ireland, even Singapore, even the US, found that during the lockdown, there were less of this extreme premature births compared to the similar time a year before. And we think that it could be the mask that people are wearing, maybe less stress at work. Yeah, so I think the mask is quite useful. Yeah.
3 tips for the pain relief. I mean, read up about the options available, and if they do decide to have an epidural, have it early. And should it be a planned cesarean section, then read up about regional anesthesia, which is a spinal, and then a general anesthetic as well. So regional anesthesia under a spinal definitely is closer to a normal delivery compared to a general anesthesia. Because the first thing you wake up from the general anesthesia is going to feel groggy, you're going to feel the pain in the abdomen, and you are not the first person to see the baby. Yeah, that's right.
I think it matters because
the bonding and all that.
You do find that the breastfeeding success rates is higher when you had a Caesar under spinal versus Caesar under general anesthesia. Yeah.